Hello, welcome to Dental Notes and Mnemonics. And today we are going to discuss about the reactive lesions of the oral cavity. It is the response of the tissues towards the irritants and stimuli. It is mostly a reactive hyperplastic reaction, and essentially a tissue overgrowth is seen due to irritation or gingiva. They are most frequently found in the areas which are more prone to irritation, especially the gingiva, followed by buccal mucosa, lips, tongue, and the palate. Now, the key characteristic of a reactive lesion, which must classify a lesion as a reactive lesion, is the 3 points I am giving. The first one is it shows the excessive tissue growth in response to a stimuli. Number 2 is be associated with the stimulus such as trauma or low grade infection, irritation. It may be a calculus, ill fitting dentures, or misaligned teeth. Or number 3 is partially or fully regress after the stimulus is removed or appropriate treatment is applied. Remember the characteristic of reactive lesions by using the mnemonic growth, where each letter of this word stands for one character of the reactive lesion. First of all, the G stands for the granulation tissue, which is formed as a part of healing response. R stands for the reversible nature of the lesions. O stands for the overgrowth due to chronic irritation or trauma. W stands that the lesions are well circumscribed and localized to the area of irritation. T stands for the trauma induced. It is caused by the external trauma or the irritation such as sharp teeth or ill-filling dentures. And H stands for the hyperplastic response. That means the cell increase in the number shows hyperplasia in response to the irritation or inflammation. And on the basis of these features, we may distinguish a neoplastic lesion from a reactive lesion, which has the potential for the malignant transformation. It may or may not be associated with a stimulus and has a limited or no change even after the removal of the irritant. Reactive lesion is a protective response of the tissue towards the injury or the chronic irritation. This may be in the form of mechanical, chemical, thermal, or the electrical insults. We'll be discussing about the common types of the reactive lesion. They may be present on gingiva, buccal mucosa, lip, tongue, or the palate. We'll be discussing each reactive lesion one by one. Before going into individual lesion, first go through this table where I have provided a subclassification of reactive lesion on the basis of histopathology. That means the tissue which is proliferating is not the same. Sometimes there may be the proliferation of fibrous tissue, vascular proliferation, there may be a granulomatous response, ossifications or the calcifications as it is found in the peripheral ossifying fibroma, or there may be the mucus secretion or the salivary gland origin as it is found in mucocele. So let's talk about the lesions reactive in the nature and predominantly involving the gingiva. First of all, the pyogenic granuloma is the most common. Second is a peripheral giant cell granuloma and peripheral ossifying fibroma. In pyogenic granuloma, patient presents with a growth on the gum that has increased in size recently and tends to bleed easily, especially when brushing or eating. A pyogenic granuloma is a common benign growth that often appears on the skin or the mucous membrane, especially in the oral cavity. Despite the name, it's neither pyogenic nor a true granuloma. Instead, it is a reactive vascular lesion that typically arises in response to local irritation, trauma, or hormonal influences. If we look for the key features of pyogenic granuloma, that it appears bright red to purple nodular lesion. It is commonly found in the gingiva, but it can occur on other parts of the oral cavity like lips, tongue, or the inner cheek. It is soft, lobulated, and may be pedunculated or sessile. That means there may be presence of the stalk, which is known as pedunculated. If the stalk is not there, then it is a sessile. Often it measures a few millimeters to 2 centimeters in size. Its surface texture is smooth, or it may ulcerate, which may bleed very easily. It shows a rapid growth and often following a minor trauma or irritation. Pyogenic granuloma, which is specifically associated with the pregnancy due to the hormonal changes, is the pregnancy tumor. It may appear in the first trimester, gradually increases in the size until the 7 months, and postpartum it regresses in most of the cases. Some lesions resolve post delivery. However, if the lesion interferes with occlusion or bleeds excessively, surgical removal during the second trimester may be considered, because the second trimester is the safest period for having any intervention. Peripheral Janssen granuloma is a reactive lesion which is commonly found in the gingiva, especially in the anterior region of the maxilla and the mandible. It appears firm, purple, or red lesion with a smooth or lobulated surfaces, and it often resembles a sessile or the pedunculated growth. It varies in the size, they may be from small to large, usually up to 2 centimeters. These lesions are usually asymptomatic, though it may bleed with minor trauma sometimes. Giant cell granuloma occurs due to stimulation of proliferation of fibroblast and multinucleated giant cells due to chronic trauma or irritation. In peripheral ossifying fibroma, there is stimulation of fibrous connective tissue with a varying degree of calcification, and this is exclusively found in the gingiva, frequently in the anterior maxilla. Peripheral ossifying fibroma is more common in the females, and usually it is seen in adolescents and young adults. It appears firm, nodular, and often pedunculated or sessile. The lesion is usually pink, red, or it may ulcerate if it is traumatized, and size is usually less than 2 centimeter. Now coming to a key management principle for all three lesions. For all the three lesions, the most important factor is preventing its reoccurrence, is ensuring the complete surgical removal of the lesion and its base. Identifying and eliminating the local irritants is crucial in reducing the chances of reoccurrence. Reinforcement of the good oral hygiene practice is important to prevent the reformation or the reoccurrence of the lesion due to the local irritants. And finally, the regular follow-up visits are also necessary to monitor for reoccurrence, especially within the first year after the treatment. The two reactive lesions which are found in palate is nicotine stomatitis, and the other is inflammatory papillary hyperplasia. Nicotine stomatitis is primarily caused by the exposure of the heat from the smoking, which leads to the ductal inflammation and changes in the minor salivary glands on the palate, and it is most common in pipe and cigar smokers. Clinically, it appears as diffuse white fissured patches with red pinpoint dots representing inflamed ductal openings. This gives it a typical cracked mud or fissured look at appearance. Symptoms are not found, that means this lesion is usually asymptomatic and often reversible with smoking cessation only. Papillary hyperplasia is a reactive lesion of the hard palate, especially under the denture bearing area. Clinically, it appears pebbly, cobblestone like red nodules which may cover a large area of palatal mucosa. These lesions are usually asymptomatic, though discomfort may occur if a fungal infection is also present. Now we will talk about the lesions predominantly involving the alveolar mucosa. The fissuratum, it occurs in the alveolar ridge or the denture bearing area, especially along the edges of ill fitting dentures or poor fitting prosthetics. Clinically, it appears as a firm, painless mass that forms in the mucosa around the denture borders. This lesion is typically smooth, fibrous, and often pink in color, but it can also appear red due to mild irritation or ulcerations. The tissue may appear folded or redundant and often following the contour of denture. The size may vary from small to localized growth to larger or more diffuse masses. First step in the management of this condition is adjusting the dentures or replacing it with a better fitting prosthesis. Regular cleaning of the denture and the oral cavity is important. Surgical removal of the fibrous mass is often required if the lesion is large and causing the discomfort. In most cases, after the removal, the lesion does not reoccur if the irritation is corrected, and followed by the regular follow-up visits to ensure that the lesion may not reoccur and the new denture fit is optimal. Smokeless tobacco keratosis is a reactive white lesion caused by prolonged smokeless tobacco use. It is most commonly found in the oral mucosa where the tobacco is placed, such as buccal mucosa and gingiva and labial mucosa. It appears white or grayish, wrinkled or corrugated lesion which may appear soft and velvety, sometimes with a granular texture. Management includes stopping the smokeless tobacco use. It generally results in mucosa returns to the normal within approximately 2 weeks, and followed by regular follow-ups to ensure resolution and check for dysplastic changes if the habit is resumed. Hairy tongue is a benign condition which is characterized by an overgrowth and discoloration of filiform papilla on the dorsal surface of the tongue. Clinically, it appears dark or discolored, hairy appearance. Affected area usually located on the posterior dorsal tongue. It is more common in the patient who are smoking or using the tobacco products, frequent uses of antibiotics, dehydration or dry mouth, and excessive tea or coffee consumption can also lead to hairy tongue. May complain of altered taste or bad breath. Include regular brushing of the tongue with a soft toothbrush or tongue scraper, ceasing smoking, reducing the tea or coffee consumption, or staying hydrated. Antifungal treatment will be required if there is secondary fungal infection. For persistent or recurrent cases of hairy tongue, especially if the predisposing habits continue, we have to do the regular follow-ups. Reactive lesion which affects the salivary glands is mucocele and the necrotizing cyalometaplasia. Necrotizing cyalometaplasia is characterized by the replacement of the normal salivary gland tissues with squamous epithelium. This condition is often mistaken for the malignant lesions due to its clinical and histological appearance. However, cyalometaplasia lacks cellular atypia and does not have invasive growth. It is self-resolving. Pain and nerve dysfunction or the other aggressive features are not seen in cyalometaplasia. An oral mucocele is a benign cystic lesion that occurs due to the accumulation of pus in the oral cavity. It results from the damage to the minor salivary glands, which causes the saliva to leak into the surrounding tissues rather than exiting through the gland duct. Less commonly, they may also arise from the obstruction of the salivary gland ducts due to blockage or the inflammation, where it is known as mucus retention cyst. And in case where there is formed by the damage to the minor salivary glands, there is a spillage of the saliva, it is known as the mucus extravasation cyst. Common location of mucocele is the lower lip, but it can occur anywhere on the floor of the mouth. When it occurs on the floor of the mouth, it is termed as the ranula. It may occur in the buccal mucosa and other area with the minor salivary glands. Plunging ranula is a type of mucocele that extends from the floor of the mouth into the neck, and it occurs when the mucus from the ruptured sublingual salivary gland escapes through the mylohyoid muscles and accumulates in the neck, leading to a swelling below the jawline. Regarding the appearance, clinically it may appear as a smooth, dome-shaped, translucent or bluish lesion. Mucocele can vary in size from few millimeters to few centimeters. Generally, this condition is painless, but they may cause discomfort, especially if they are large. They may periodically rupture and refill with the fluid. Of mucocele, in case when they are small, they may resolve on their own without any intervention. Surgical excision may be required if the mucocele is recurrent or if it is large. In very large or in case of granulomas, we do marsupialization, which involves creating a permanent opening to allow the mucus drainage, and laser therapy has been also used to remove the mucosal, minimizing trauma and bleeding. We'll talk about the traumatic neuroma, which is a benign non-cancerous growth that arises from the nerve tissues following a nerve injury or trauma. This lesion results from the abnormal regrowth of the nerve fibers and supporting tissues and is usually associated with the history of surgical procedures, accidental trauma, or the dental extraction. On palpation, traumatic neuroma may feel firm and movable and elicits pain or discomfort. Management comprises of surgical excision, where the complete removal of the neuroma along with the portion of the nerve is done to prevent the recurrence. Pain management is done through non-steroidal anti-inflammatory drugs or other analgesics for the relief only. Corticosteroids injection may be considered to reduce inflammation and the pain in some cases. If we compare the traumatic neuroma with the similar appearing other lesions of the oral cavity, fibroma is typically painless and non-tender and no history of trauma required for the formation. Lipoma is soft, painless and movable. No nerve involvement or associated pain is there. Neurofibroma or schwannoma may be painless, often larger and more encapsulated than the traumatic neuroma. Now we'll learn about the lesions which are not specific to any particular site. First of all, we'll study about the irritational fibroma, which is also known as traumatic fibroma. It is a common benign fibrous growth in the oral cavity. It typically develops as a response to chronic irritation or trauma such as cheek biting, ill-fitting dentures or rough tooth edges. These lesions are made up of dense fibrous tissues and are usually painless. Clinically, irritational fibroma appears as small, firm, dome-shaped nodule, typically pink in color, which is similar to the color of surrounding tissue. This remains usually painless, though it may cause discomfort if it is irritated. Of the lesion is the primary treatment for fibroma, and typically it is curative also. The source of irritation should be eliminated. The patient should be followed up to ensure that there is no recurrence or ongoing irritation at that site. Now we'll talk about the oral lipomas. Oral lipomas are rare. Lipomas are benign tumor composed of mature adipose fat. They are commonly found in the buccal mucosa, floor of the mouth, tongue or the lips. Clinically, they appear soft, smooth, often yellowish, or they may appear encapsulated and well defined. They are generally very small, but they can grow larger if they are left untreated. Treatment is surgical excision, which is typically curative, and recurrence is rare. Let's talk about oral ulceration. Oral ulcers is a common reactive lesion, arises due to localized tissue injury or irritation. It appears as a break or the erosion in the mucosal lining, often accompanied by painful red border with a yellow or white center. Reactive lesions can be caused by trauma like biting, sharp teeth, dental appliances, chemical burns, or the thermal injuries. They are typically short-lived, healing within 7 to 14 days if the irritant is removed. Persistent ulcers, however, may suggest underlying systemic condition of the infection. This is usually clinical, focusing on lesions appearance and the history of irritation. Management includes removing the cause, symptomatic relief with a topical analgesic or the soothing rinses. Frictional keratosis is a white lesion that appear in the oral cavity due to chronic mechanical irritation from any denture or a rough teeth. It is common on the buccal mucosa, tongue or the area which are in contact with the irritants, and clinically it appears as a white, rough, thickened area that blends with the surrounding mucosa. Aspirin burn is also a reactive lesion in the oral cavity. It occurs when the aspirin is placed directly on the oral mucosa, usually in attempt to relieve the dental pain. Aspirin is acidic in nature, so it causes chemical burn which leads to the tissue damage. Clinically, the aspirin burn, it appears as a white, necrotic or ulcerative lesion with a well-defined border. The area may peel off, leaving red raw tissue beneath. Healing of aspirin burns usually takes 7 to 10 days if the irritant is removed. This was all about the reactive lesions of the oral cavity. Please go through the summary charts, and they will help you to memorize and revise whatever we have learned till now. Thank you all for watching and learning with us about the reactive lesions in the oral cavity. I hope this video has clarified the different types, causes, and the ways to manage these common conditions. If you found this video helpful, please consider liking, sharing, and subscribing to stay updated on the future content. Till then, bye bye. Take care. Have a nice day. Thank you. Thanks a lot.